Children with epidermolysis bullosa require careful preoperative assessment. This child with dystrophic EB is scheduled for an elective surgical procedure to release pseudosyndactyly. These children have often undergone frequent previous anaesthetics. Careful review of the notes and discussion with the patient and family can reveal vital information to assist the conduct of anaesthesia. Contractures and scarring can result in the patient presenting with a potential difficult airway as a result of reduced neck flexion and extension, reduced mouth opening, poor dentition, and a fixed tongue. In our experience, about 25% of patients who present to theatre have a difficult airway with a Cormack or Lehane grade of 3 or more. Stridor preoperatively is a particular significant sign, and laryngeal bullae should be considered. In addition to a standard anaesthetic consult, areas to consider and plan for are the potential for difficulties in establishing intravenous access, assess for gastroesophageal reflux risk, assess cardiac function. Blood results may reveal anemia or an altered renal function. Review their current medication, in particular any medicines for chronic pain or steroid supplementation. The psychology of the patient. Are they particularly anxious? What has worked well for them for previous anaesthetics, and try and agree a plan of what will happen in the anaesthetic room. Pre-medication with an anxiolytic or play therapy is often advisable and allows the child a less stressful, smoother induction. A child who struggles and resists induction of anaesthesia is at greater risk of injury and bullae formation. Allow time to prepare the extra equipment you will need for a child arriving to theatre who has EB. Storing all the dressings in one place often saves time. Cling film, lubricating jelly and non-adhesive dressings are essential. Greased, non-ridged oxygen masks dressed with Gelinet dressings avoid injury to the face. At Birmingham Children's Hospital, 3/4 of our patients with EB are induced with inhalational anaesthesia because of associated difficult intravenous access. Your laryngoscope should also be well greased. When the patient's mouth opening permits, video laryngoscopy allows excellent visualization of the laryngeal inlet whilst minimizing the trauma associated with standard laryngoscopy. This is now the preferred approach at Birmingham Children's Hospital. One tip to ensure successful intubation once the vocal cords are visualized is to mold the shape of the endotracheal tube to the hockey stick shape of the video laryngoscope. To avoid injury to the airway, ensure any stiffening stylet does not protrude beyond the end of the endotracheal tube. Where mouth opening is restricted, fibre optic nasal intubation is preferred. In patients with a known difficult airway, having a fibre optic scope available and ready to use is an essential backup plan. Preparing the airway with atomized local anaesthetic spray is useful to allow the patient to maintain self-ventilation and avoid laryngospasm, whilst passing the endotracheal tube through the vocal cords. Anaesthesia for patients with EB is a challenge. The principles of safe anaesthetic practice should be maintained in conjunction with minimizing friction with well-lubricated dressings to avoid new bullae formation. Traditional hospital bracelets have sharp edges and can injure the skin, so we either pin them to the patient's hospital gown or use a photo for ID. This patient's 0.5 per kilogram of midazolam pre-med has worked well. He is sedated, but still cooperative. It is clear that the intravenous access is a challenge, and so we have elected for a gaseous induction. Before we start though, we shall ensure essential monitoring is established. Cling film is used to wrap around the finger and the adhesive oxygen monitor is placed on top. The infrared light of the monitor is not disrupted by the cling film, which prevents the sticky probe from injuring the skin upon its removal. This is being demonstrated by the patient's EB nurse, who accompanies the patient to theatre in order to advise the theatre team on the best dressings for each individual, and also ensures that theatre staff who may occasionally encounter patients with EB are supported. For some children, ECG electrodes can be placed directly onto the skin and removed using an anti-adhesive spray such as Niltac. Other children may require 3M defibrillation jellies to be first placed onto the skin to conduct through to electrode. A combination of nitrous oxide and sevoflurane is used to induce the child. Gelinet is used to protect the face from injury as the patient is supported to achieve an improved airway under anaesthesia. Avoid friction when cleaning the skin for intravenous cannulation. Simple direct pressure to occlude the vein is as effective as a tourniquet and also avoids friction. A non-adhesive Mepitel transparent dressing secures the cannula. Hard plastic attachments can easily injure delicate skin, and so they are padded with gauze. Remifentanil is a potent, short-acting opioid which is useful when you wish to achieve excellent analgesia during surgery, but aim for a rapid awakening when surgery is completed. Here it is also being used to attenuate the cough reflex whilst intubating the patient who is self-ventilating in oxygen and sevoflurane. Visualization of the vocal cords is achieved with the video laryngoscope, and the cords are sprayed with lidocaine. The endotracheal tube is carefully placed into position and the supporting stylet removed. In this case, the endotracheal tube size that is selected is a little small. There is a large leak around the tube when attempting to intubate that is shown here by the bubbles appearing around the endotracheal tube. Our practice is to place an effective endotracheal tube for the patient's ventilation rather than what is traditionally described, which is to choose half a size smaller than estimated by age. Keeping the video laryngoscope in position to minimize trauma, we change the endotracheal tube by railroading the larger tube over a bougie. End-tidal carbon dioxide, seen here in the orange trace, gives final confirmation of a successful intubation. Traditionally, the patient's eyes are taped shut during anesthesia to protect the eye and prevent drying of the cornea. For EB patients, we avoid tape and use gel to protect and keep the eyes shut. The head is then wrapped in padded gauze lined with Gelinet, and the endotracheal tube secured with a tie that does not rest on the patient's face. Attention to details is important. Here we ensure the tube tie doesn't rub on the angles of the mouth. An oral thermistor temperature monitor, as long as it is well greased, is safe and effective at measuring the patient's temperature intraoperatively. Non-invasive or intra-arterial blood pressure monitoring can be used depending on need. Here we see the non-invasive cuff being placed over a dressing lined with Gelinet gauze. Here, a dressing is removed using Niltac spray to avoid skin damage. Careful transfer and placement of the child on the operating table is required without sliding the patient. The child is placed on an absorbent mattress cover to avoid the skin sticking to the plastic of the operating table. In our theatres, we use an operating table heating mattress to reduce patient heat loss. Here we will use desflurane for the maintenance of anaesthesia together with remifentanil for rapid wake-up at the end of surgery. TIVA using propofol and remifentanil is equally as effective. Padded, Gelinet-lined tourniquets can safely be applied and are effective at reducing blood loss and improve the visualization of the surgical site for the surgical team. As surgery finished but before waking the patient, it is important to check for nubuli that may have formed, especially in the patient's airway. If any are found, they should be punctured with a sterile needle to deflate and prevent enlargement. Suctioning the pharynx under direct vision prevents trauma. The patient is still anaesthetized and is self-ventilating with normal tidal volume. The patient is extubated deep, the anaesthetic agents are switched off, and the patient rapidly awakes calmly.